Hello, everyone. Good morning, good afternoon, good evening, depending on where in the world you are and when you're watching this. I want to welcome you to a corporate forum by Snoasis, and I want to thank the American Academy of Perio, the Japanese Academy of Clinical Perio, the Japanese Society of Perio, and Snoasis for giving me the honor of presenting to all of you. This is a very scary and strange time for us in the world, and I want to send prayers and best wishes to all of you who are suffering, who may have lost people near and dear to you, and who may know people who are suffering. Again, my heart goes out to all of you. So, what are we going to talk about today? We're going to talk about an interesting kind of barrier that you may or may not be familiar with. BioXclude, an Amnion-Chorion barrier. And for those of you who don't know me well, let me just move my head out of the way. Yes, this is actually the way I am dressed. So yes, we can be formal, we can be informal, but as long as I'm not right in front of you, we may as well be comfortable. So yes, I would love to be there with you and share a beer, a glass of wine, and a hug and a handshake. But for now, I'm going to have to answer your questions either in the chat or by email, which you'll see on the bottom left of your screen. So please be sure to send me emails if you have any questions about anything. So let's get started. What is BioXclude? Where do we get it? Where is it from? Those of you who've seen some of the other corporate forums today by Snoasis on this amazing product really have a good idea about it already, and I don't really want to go into too much detail because you know a lot about it already, but I will go into some detail for those of you who may not already. We'll talk about where it's from, where it's used, why to use it, maybe a little bit about why not, and a little bit about my progress in it as well. So I have private practices in the suburbs and in Manhattan. I do teach at NYU in the Department of Oral Surgery, and I happen to be part of a relatively new organization called the International Association of Dental Specialties, where I'm the head of the section on biomaterials and regenerative technologies. And again, if you have any questions, please email me on that as well. So, as a periodontist, I face a lot of challenges that my patients bring me, and you as well, whether you're a periodontist, oral surgeon, prosthodontist, or any other dentist that's out in the audience, you will also see challenges in your daily life, whether it's surgical or non-surgical patients. And they fall into two different categories. One are the different sites that may be challenging our patients, whether they're near a sinus or an inferior alveolar nerve. Does a patient need, or demand an implant to be placed in an extraction socket? Do we have teeth that are missing bone near a tooth that has to be extracted? Or is there an implant that's missing bone? Something that we didn't think would happen when we first learned about implants 35 years ago, but now we know that it's up in the range of 50% of our cases. But also some patients have what we used to call piss poor protoplasm. These patients are at risk due not only to poor home care, but genetic issues, history of periodontal disease, smoking, cancer, lots of different issues that can affect the patient's ability to maintain their oral hygiene, to maintain their mouth free from inflammation, and certain components of their body that may prevent them from maintaining alveolar bone. So let's look at some of them. We'll start off with a nice, easy one. Of course, our relatives often present the most difficult cases. In this case, we have limited bone. We have decay below the alveolar crest. We have a patient who has poor home care and is poorly compliant with recare. So what do we have to do? We have to decide first, are we saving or extracting the tooth? When we don't see prominent nerve canals, when the endodontist doesn't think that they can treat the tooth predictably, we know that we're running a risk of endodontic failure. So we look towards extraction. When we see a history of restorative issues in the mouth, that also leads us to extraction in this patient. But thin bone, thin biotype, we know we're going to have potential issues. When we see that the decay is below the bone, we know we're going to need to do an atraumatic extraction to preserve as much of the bone and as much of the thin buccal plate, to preserve that thin biotype as much as possible. So we're going to section the tooth. We're going to use our Mectron piezo surgery to remove the individual roots as easily as possible. And we're going to go with our dental anatomy as we know, using periotomes, using microforceps. Once we do that, then we're going to want to regenerate the site. We're going to go, in this case, using both allograft and a bioactive barrier. We're going to use the BioXclude because it's going to give me the advantage of giving a lot of very good, very positive healing effects. And you're going to see very shortly why it's going to be a help in this patient. As you can see on the left, we have very thin biotype on the buccal, but you also see we haven't elevated a flap. So what are we going to be able to do with the BioXclude without elevating a flap? We just tuck the BioXclude right under the buccal and lingual tissue without elevating a flap, right over the allograft. That allograft was just hydrated in saline and the blood comes right up through it. Unlike other barriers where you have to elevate a flap and tuck 2 to 3 millimeters under the gingiva, the BioXclude just goes right under the free gingival margin. So it prevents you from denuding the little bit of periosteum that's on the bundle bone. So what do we know? If we want long-term success around our teeth and our implants, we know from Linkevicius's work that the 3 millimeters of keratinized tissue, of soft tissue, may be more advantageous to preserving bone than what Boozer and Grunder have said for years, 2 millimeters thickness of alveolar bone. We know we need a certain amount of alveolar bone because we know we need a buccal and lingual plate. We need intrinsic bone supply, whether it's around teeth or around implants, especially like Woody, the patient on the bottom, who's a smoker. We need our patients to be able to clean, whether it's under bridges around individual teeth. We need the proper restorative principles. All of this has to be determined before an extraction or if a tooth is going to be saved, so we can get the best long-term prognosis for our patients so they can clean areas, keep them free from inflammation, keep food from packing in and under restorations. Sometimes in the past, and even still, we're going to use titanium reinforced Teflon barriers. We may use collagen barriers to thicken the soft tissue to get to that 3 millimeters of keratinized and soft tissue like Linkevicius says. We may use other synthetic barriers, but again, that's not the point of today's talk. Today, we're just going to be discussing the BioXclude Amnion-Chorion barrier. Advantages include the fact that there are no allergic reactions to it because it's immunoprivileged. It is anti-inflammatory, it's antiseptic and antibacterial. So even in patients who have infected and inflamed gingiva, you can put this in and you will not get infection. The patients have less discomfort. They have much better healing, and it's been investigated in various forms for over 100 years. There have been over 1 million cases to date in many different indications and publications in everything from neurosurgery to sports medicine. And that's where it comes from. It comes from the placenta, donated, never taken without anyone's permission. And what is the advantage of the BioXclude is it has the amnion and chorion, which none of the other membranes taken from the placenta have. The other ones are only amniotic membranes. What does that give us? It gives more collagen. It gives us a thicker membrane, more to use. It also gives you the ability of getting way more growth factors. You get almost 4 times as many growth factors with the Amnion-Chorion membrane, the BioXclude, than the amnion alone. So wouldn't you want more PDGF, more TGF, and more VEGF in your barrier than just a passive or a non-bioactive barrier. So to me, if I have the ability to get where I want it, where I need it, a thicker Amnion-Chorion barrier, if I can get more growth factors than just amnion alone, if I can get a bioactive barrier, which gives me the ability to have no memory, to place it where I need it, when I need it, I have all the advantages I need to get healing that starts, and again, a patient who has poor home care, you can see the inflammation where no incision was made, and look at all the ridge width that was preserved. You can still see where she has inflammation, where she's not cleaning. Didn't get any better in the 4 months, but all the ridge width was preserved, all that extra keratinized tissue, which gives us all that beautiful bone. You don't see graft particles. You don't see granules. What you see looks like real bone there, which gives us the ability to place a dental implant and get an ideal screw retained restoration, something that she can maintain with real ease and with better home care than she possibly could around her natural teeth. So if we can do that for our simple quote unquote patients, wouldn't we want to do this with patients who have red flags waving at us? Let's see what those look like. What happens with patients like this? This is not necessarily a surgical patient or a surgical issue that caused this problem, but these defects, these restorative issues, whether they're caused by the lab or the dentist or the patient not cleaning properly, leave the periodontist or the oral surgeon or the restorative dentist who's doing surgery with issues, because these often cause decay under the gum line. And we have to come up with, like in Cousin Amy, the best ways to treat it with doing minimal amounts of surgery at the same time. Because even though aesthetics always tend to be an issue for our patients, there's more at stake, because we need to preserve and augment the bone. We need to preserve and augment the gingiva. So let's take our first at-risk patient. Here's Allie. She's young, she's healthy, but what do you see? We see site collapse on 17. We see a tremendous amount of destruction of tooth. We see thin biotype. We see what's probably bone missing on the buccal plate and the other teeth. What do we know? We know she's had anorexia and bulimia. So we have to assume that even though she's doing better now, she may not heal properly after all the surgery. So anywhere I can, where I know I'm going to need a lot of tissue, I'm going to look for ways to use bioactive materials on her. I'm going to try and do the best I can to restore these buccal plate deficiencies for her. So what are some of the questions we have? What do we have that limits our anatomy? What are our biotype issues going to be? And how does her health history affect us? And because of that, what are our graft choices going to be? And can we look maybe at a couple of different grafts and barriers and see how they handle in her to give us ideas for future patients and how those are going to be handled? So when I did my training, I had the unbelievable good fortune of studying for a few years under Stu Frome and Dennis Tarnow, who asked me to come back and take 2 years, 2 days a week out of my busy practice and study with them at NYU. And while I was there, I also had the amazing fortune to be stimulated to do research, not only by them, but by Andy Toffe, who not only got me to do research, but really was the first one to bring growth factors into dentistry. And I really do owe all of them a debt of gratitude. So let's look at the grafts and barriers we used and really how they handled an alley. So here we have no and thin buccal plate, no and thin buccal plate. So yes, there are a lot of patients who receive immediate socket dental implants in these areas, but we don't really have literature showing histologic bone to implant contact in these sites. So in a patient who has a history of an eating disorder, who may not heal at the same speed or even amount that other patients do, I'm not willing to risk that limited healing on her. I want to get the maximum bone volume and the maximum amount of keratinized tissue in all 4 of these sites that I can. So I'm going to look carefully at the questions that I have to get me to the long-term results of what's going to get me bone volume, what's going to get me keratinized tissue, and am I going to use passive or bioactive grafts and barriers? And if I have a possibility of using both, let's see if I can study and look at one versus the other. So in the anterior, where I have multiple walls and I should be able to get a good fill, I'm going to use just allograft in the sockets. I'm going to use just a passive graft material with no growth enhancers. In the posterior, where I have more buccal plate missing in the second molar site, and where I have to do a lateral onlay graft in the first molar site, I'm going to use an allograft that was tested positive for osteoinductivity, and I'm going to add calcium sulfate. The same 20% that David Anson and John Sotosanti showed us, that we know Aru Haimi and others have showed us, give us osteogenicity, and that Stroke has showed us gives us angionicity. But in addition to that, and you can see where the grafts are, and you can even see where the allograft alone, after a few minutes, the blood supply comes through it. I'm going to also use 2 different barriers. So over my bioactive graft, I'm putting my bioactive BioXclude barrier, and over my passive graft, I'm putting my passive dense PTFE barrier, which I've used for 25 years and have loads of success. And you'll see the volume of bone and keratinized tissue that we get from that. So closure, we don't need primary closure over the dense PTFE, and we don't need dense primary closure over the Amnion-Chorion. So we wait 8 months and we see bone fills fully in the molar site. We have good height preservation everywhere, but the allograft alone over the dense, with the dense PTFE over it that was removed at about 5 weeks when some of it became exposed, we can still see the root sockets, and that's 8 months later. So already I have just a little bit of a question about what the healing is going to be like in that area histologically, or even clinically when it comes to the density of the bone. So when we look clinically, we see where the dense PTFE was removed. We did get a little bit of expanded keratinized tissue, and we know that from Barry Barty's work, Hoffman's work, my work, and others, and we got a large expanse of increased keratinized tissue in the posterior where the BioXclude was placed. Why are we getting all these great results from the BioXclude? Look at all the growth factors like we showed before: PDGF, TGF-beta, and alpha, interleukins, VEGF, everything we need to get better healing, not only of the soft tissue, but you saw in the difference in the radiographs of the hard tissue as well underneath it, and better migration of the mesenchymal stem cells. So look what we see in the bone. These implants have a 6.5 millimeter wide platform where the bioactive graft and bioactive barrier was placed. But look in the anterior. These are 3.5 millimeter implants, and the bone was so weak in the anterior site that it couldn't even maintain the stability of the implant when it was placed. That implant migrated 0.5 millimeter to the buccal. And yes, the implants all became stable and all integrated, but look at that bone density in the second molar site, just a few residual particles of the allograft, all the rest nice dense bone. And this is the lateral onlay graft. Allograft particle, allograft particle, allograft particle with new vital bone all around it. Lots of dense keratinized tissue in the posterior, and yes, some keratinized tissue in the anterior, but again, more inflammation in that anterior site. So what did we see? We saw better bone in the posterior, wider bone in the posterior, and more keratinized tissue, all with the bioactive graft under the BioXclude barrier. So we need to understand the patient's anatomy and the variation, both physiologically and anatomically, and where the biology of the grafts, where the biology of the wound healing, where the biology of the barriers comes in. Because we have to know the difference, and we have to educate our restorative partners as to where that comes in. We have to know that every single part of every case has to be treated to the best standards. We're specialists. Our patients demand that of us, just like our teachers demanded that of us in our trainings. Whenever I can, I add bioactive materials. Whenever it's possible, and definitely in my challenged sites and challenged patients whenever they're needed. When I do that, I find life is way more relaxing and more enjoyable. So you may not enjoy jumping off cornices like this, but it definitely helps when you use the bioactive materials, helps you to take the easier way. And yes, there is literature on it. This was a split mouth study on Amnion-Chorion versus dense PTFE barriers. And what they did in these patients is they compared bone volume, keratinized tissue, discomfort after the extractions, and histology. So what they found is clinically no difference in volume, but what they saw was a large difference in the amount of vital bone, where there was better bone under the BioXclude and less discomfort in the BioXclude. So the patients were healthier and healed better and were happier. So to me, all those are good signs. So what do we know? We learned all throughout our training that if we can, wounds heal, and we want to make them heal better, whether it's just soft tissue grafting like you see in the middle, or whether we're saving teeth like David Anson showed in his article, when we can save the tooth if possible, and if not, place an implant, or the article on the right side where Ziv and I, with George Katsakis, talked about how dentin grafts mature over time. So let's look at some more challenging patients. So here's my FedEx driver. Simple extraction of an upper left central. Implant was placed 4 months later, loaded 4 months after that. Lo and behold, whether there was an infection due to the lateral incisor or due to his 2 to 4 month a day smoking habit, I can't tell you, but whatever happened, once that implant came out and that infection continued from the lateral, we ended up with a large hole. It was a massive site that now required a major surgical procedure to treat. And you can see the size of that hole in the upper central. So now we have a really challenging patient and a very challenging site. He's going to be wearing an Essex retainer, so there's no soft tissue pressure. We're going to get in with debridement burrs. I'm going to put in a platelet-rich fibrin block of allograft, and I'm going to use a dense PTFE barrier that has a titanium reinforcement strut because I want physical shape of my graft. And we're going to close everything up with primary closure and see how it heals. We're even going to use a tack to stabilize it because we were told what matters: holding the shape of the graft and stabilizing it in place. So let's see what happens. What I don't have the picture for you is that a month and a half later, with all of his smoking and his lousy home care, I had to pull that barrier out, tack and all. So here we are 6 months later, and when we evaluate healing with the software, with our CT-guided surgery, what do we see? We see very little to no bone in the central, and we see a through and through hole in that buccal plate. Not at all ideal for us. Can't place an implant in the central. We can only place one with guided surgery using our Versa burrs to optimize bone to implant contact, expanding that buccal wall for ourselves to get an implant in that lateral site. So that's the only way we're going to at least get one implant in, but the restorative dentist and I aren't going to have faith that one implant is going to suffice for him. And then again, on the right side of your screen, you can see in the software where that through and through hole is in the buccal plate. And here you see clinically where that hole is in the buccal plate after the implant was placed. So again, we're going to make another PRF block. But what am I going to do? I'm not going to use the same barrier. I'm going to try and use a different barrier that's going to give me better healing, because now what I see is there's also a fistula through the palatal soft tissue. So now we not only have a bone issue, but fistulas to deal with as well. So what we want is physical and biological advantages. So the PRF block will give me the physical ability to hold the graft in one place, and biologically it will give me some amount of release of growth factors from the site, which will stimulate cellular activity and help some amount of soft tissue healing. What will the Amnion-Chorion barrier give us? We surely know it's not going to give us any physical stability, but biologically, we've seen the list of growth factors that it will give us. We know it will give us recruitment of mesenchymal stem cells, and we know it's anti-infective. So let's see what happens. We know from more studies that we can get more vascularization. We know we need a blood supply to help on our wound healing. That vascularization should help both the soft tissue and the hard tissue for us. Mesenchymal stem cell recruitment should also bring us more bone, better bone, and quicker bone. So let's see what happens in 6 months. Nothing gets exposed, no bone, no soft tissue. Look how wide the ridge is in that middle picture. So we just add a little bit of porcine xenograft to support the soft tissue to give us a better emergence profile, but the implant is exactly where we need it, again, placed with our dynamic surgical navigation, and we close everything up. We give him a mouth mate so that he can brush around it and not damage the surgical site. The implants are uncovered, abutments placed, and he gets restored. So let's take another patient. What do we have? We have surgical issues, we have restorative issues. If you look at the x-ray on your right, you see that the first molar is infected all the way up into the sinus. You see a large mesial concavity on the second premolar with a large infraosseous defect on both the canine and the premolar. Most people would say that both of those teeth have hopeless prognoses, and I would say that both of those teeth holding the bridge do have poor to hopeless prognoses, as we would have discussed back in our implant program. Clearly, the molar is hopeless. So if we look at the clinical shot, the occlusal view, if we take out the molar and we take out that upper left bridge, we know we have similar periodontal conditions on the right side. She's going to be in trouble. If we lose the bridge on the right and that upper right molar, she's going to end up with a partial on 4 incisors. And with limited finances, that's really not going to last her well. So we need to do everything we can at the same time we take out that molar to use whatever bioactive materials we have at our disposal to try and preserve and augment the tissues around the canine and premolar and try and get any periodontal regeneration we can. This is from a company called Oral 3D. They have great software that lets you print up models from your CBCT scans that shows the oroantral fistula that we already have, even before extracting the tooth. So I can explain to the patient how difficult this surgery is and what I'm going to have to do, why I need the different bioactive materials to both try and save the 2 teeth holding the bridge, but also to preserve and protect her sinus integrity. So this is, again, not simple perio treatment, not simple extraction therapy. So what do? We have to try and save everything other than that first molar. So let's look and see what it looks like open. You can see the size of those defects, and what you couldn't see from the x-ray, there's also a 6 millimeter infrabony pocket on the distal of that premolar. So what are we going to use for our graft? We're going to use the most bioactive bone graft there is on the market, and that is the tooth. We're going to do green dentistry and grind up the dentin to become our bioactive graft for her. So while the dentin is being sterilized, processed with the Cometa biodentin grinder and processed, I'm going to be doing my root planing. I'm going to treat the tooth with EDTA, both the distal of the canine and the mesial and distal of the premolar, so that the tooth is more receptive for regenerative procedures. But look at the mesial of that premolar. That's practically a zero wall defect. 1 to 2 walls on the distal, and 0 to 1 to 3 walls on the distal of the canine. Again, not simple periodontal therapy. What do we know about the ground dentin? Lots and lots of literature, clinical, histologic, biologic, physiologic reports on what it can do for us, the growth factors it contains. Marshall Urist going back to 1965, showing that there are BMPs in the ground dentin. A perfect match for a bioactive barrier to try and preserve both the socket and the periodontal defect. So we take our BioXclude, we put one piece over the oroantral fistula. We take our ground dentin and we fill the infrabony defects, again, after they've been adequately root planed, after they've been adequately debrided, after the teeth, both the mesial and distal of the premolar. And on this view, you can see the defect on the distal of the premolar. After they've been root planed and treated with EDTA, we graft the entire extraction socket. And then we're going to cover everything with the Amnion-Chorion barrier, the BioXclude. And now we go for primary closure, and we wait and we pray. So again, the Amnion-Chorion barrier gives us the antiseptic, anti-infective nature. It'll prevent the biofilm. It gives us all the growth factors and cell recruitment that we need to get the appropriate healing, which we don't have the growth factors and binding proteins in collagen barriers. What about PRF? Yes, I use a lot of PRF. However, in 3 controlled studies, bilateral studies where they looked at bone healing, soft tissue healing, and looked at them carefully, there was no statistical difference between the PRF side and the non-PRF side. So we use it, it makes us feel good, but there's no statistical significance with the early types of PRF that have been used. We don't have enough data yet on Rick Miron's new system. That's still being investigated. So look at the x-rays, 6 months and 12 months out. By 12 months, the distal of the canine, the mesial and distal of the premolar, what are we seeing? We're already seeing PDL reformation. We're seeing evidence of true regeneration. We see a clear sinus. We see bone formation in all the defect sites. But what else? We see minimal probing depth, where you had a 6 millimeter infrabony pocket on the distal of the premolar. It's 2.5 to 3.5 millimeters. The distal of the canine is 4 millimeters. Look at the 3D reconstruction of the initial defects and see how large those were. Look at the initial oroantral communication. The mesial of the premolar was originally a 9 millimeter defect. Now with probing to blanching, it's only 3.5 millimeters. So what else? Immediate socket implants. We'll talk about her risk factor in a minute. If I can, I like to try and keep the buccal plate near my implant. That doesn't mean I don't want a gap, but that little bit of a buccal plate from the palatal root socket, because this was a 2-rooted second premolar, I'm going to move forward. How? With my vertebrae. So what I'm going to do is I'm now going to place that implant with some vital buccal bone around it. But I still want a graft. I want a slowly resorbing bioactive graft with a bioactive barrier around it. So I'm going to place my ground dentin and I'm going to place my BioXclude barrier over it. And that is the tooth placed about 5 to 6 months later over the immediate socket implant. You see the ridge width preserved. You see the height of keratinized tissue preserved. Why? Because what the dentin helps us do is take the M1 macrophage, which is what causes the destruction of inflammatory tissue, granulation tissue, and dead bone, and converts it to M2 macrophage, which is more like an osteoblast, more like an osteocyte, the formative, the bone regrowing type of cells. So here is what Hildy looks like in 2017. Here's what she looks like in 2018. Here's what she looks like in 2019. And here's what she looks like in 2020. So if we were live, you'd ask me, what's her risk factor? Her only risk factor when I started, she was 96 and a half, and she's now 100 and a half years old. So 4 years out at over 100, I would consider this pretty darn good success. Yes, Chuck Schwimmer, Howie Glucksman would say you should have done partial extraction therapy. And if I had more intestinal fortitude, I probably would try it one day. One day I will. I promised them both I would. All right, so what do you do if you have a patient who at 72 years old starts smoking? What do you do? He now has a lower central incisor that becomes infected and takes half the bone off a one-piece implant. Again, when we did our treatment planning sessions in the implant program, Dennis had us use checks, question marks, and X's. So there's no bone around the left central, that's gone. There's 60% bone loss around one lateral, 90% bone loss around the other lateral, and 30 to 45% bone loss around the implant. So if we were all together at a bar or in a school seminar or in a classroom, I would ask, which of these four, or are you taking out all four? Are you just making a 6-unit bridge between the two canines? Well, not every patient necessarily wants an implant and other teeth removed if they think there's a chance to save them, and not necessarily with just shining a light under the gum line. And yes, I know there are some studies coming out on some amount of short or long-term preservation and increase of bone around implants. But to me, in my hands, I have a better response if I can physically see the surface, debride the surface, and graft the surface. So we know when there's root proximity, what do we have? A difficult time cleaning and a difficult time to get vascularity there. And with a smoker, we have less blood supply. So let's see what we're going to do. So we take out that one tooth and we make partially demineralized dentin. We're going to use that as our bioactive graft and BioXclude as our bioactive barrier. I am going to root plane. I am going to treat the roots with EDTA. I am going to use my erbium YAG laser on the root surface. I am going to use a high-speed burr on the root surface, and I'm going to use iodine on the root surface of the implant to get it as clean as possible. I'm going to place my bioactive graft. I'm going to place in the middle picture, you can see the Amnion-Chorion barrier over it. I'm going to place the sutures to get primary closure. I'm going to place a 2-unit temporary bridge, and Vinny and I are both going to say some prayers. So that's initial. 18 months later, new bridge is inserted, and we are now only missing one thread of bone on the implant. We have tremendous amount of bone regrowth on the adjacent teeth where you see a PDL on both of the adjacent teeth. Where there was 35% bone loss on the distal of the implant, 2 millimeter pocket with blanching. On the mesial, where there was 45% bone loss, 2 millimeter pocket with blanching. That's the new bone level. That's the original bone level. What about here? Same thing. Tooth is taken out. What we want to do is preserve that very thin buccal plate, preserve the alveolar height, and get some root coverage if we can on the adjacent teeth. Again, we're going to use ground dentin because we know that it preserves bone. We know Marshall Urist showed that. We know that Nampo shows that there's better bone than iliac crest and other bone grafts. BioXclude, 226 growth factors. So where we had recession, we're going to graft. That's where the socket graft was. 2 months, 7 months later. And that's the amount of fill we got. And look at all the thick keratinized tissue in the middle of that extraction socket with no primary closure. 8 millimeters of extra keratinized tissue. And now we're going to do a VersaLift, just like Salah and Ziv have taught us how. Place the implant. We're going to add now Chem 21 to get predictable regeneration on the root. That's what we started with, 15 millimeters before the first surgery. Now, if you look, you can see over halfway up the root is the coverage we got after the dentin graft with BioXclude over it. And that's where we are with the first dentin graft plus the additional Chem 21. So out of time, but not out of ideas, but understand patients will always try and defeat us. Their history and their risk factors is something that we always have to understand. No matter what happens, biology is always going to win, and we need to have it on our side. Why do I like BioXclude? Because it's bioactive, it's antibacterial, and it helps where you need it. Not only in the challenging cases, but like you saw in Cousin Amy, in the regular cases too. Yes, you saw that I do use other barriers. I still use collagen and Teflon, but the BioXclude barrier we're using in regular cases, in challenging cases, and you saw what it does in these cases with helpless teeth and hopeless implants. And if it does that in those cases, imagine what it'll do for your simple cases, because we have the literature, we have the cases, and we have the histology to back it up. So I thank all of you for your attention. You see my email address on the bottom. Please send me emails. And if you're in a school program, talk to your program director, get Snoasis on the phone, see if when the world opens back up, you can get me down there or across there, wherever that is. And maybe we'll do the same with getting me out there to a study club with a bunch of grown-up periodontists as well. So enjoy the rest of the meeting and the rest of your day. And thank you for your time.